Good day, friends of Buzzy. So this is a very important day because tomorrow, August 24th, I will be beginning the randomized controlled trial that University of Augusta has graciously mobilized everyone to put together. This randomized controlled trial will be looking at two different kinds of nasal irrigation in COVID positive patients who test positive from the one site in Augusta University, and looking to see whether or not patients who use nasal irrigation are less likely to progress to needing to be admitted to the hospital, intubated, ICU, or death. How did we get here, and where is everyone in the world with evaluating how COVID goes into the nose and how nasal irrigation or nasal treatments might help? Story time. All right, so going back to March, there were a couple weird things about coronavirus that those of us in the medical field noticed. First of all, it was extremely dynamically loaded on the back end of life. We're used to seeing the very young and the very old have weak immune systems and get sick, but we're not used to seeing children rarely get sick and adults having a 40 times higher rate of dying than children. So that was weird. Over the next couple months, it became apparent that there were risk factors that were unusual in who got sick. Obesity, diabetes, hypertension, those people were getting very sick, but people with asthma, people who had had cancer and were recovered, people, in fact, who had immunodeficiencies or were on immune blocking drugs for rheumatology, for rheumatoid arthritis, for Crohn's disease, things like that, they weren't getting sick as often as we expected. Other weird things were that the disease seemed to have a differential impact on different parts of countries and in different parts of the world, with Southeast Asia having very few cases and a dramatically lower case fatality rate than Italy or than New York. So what could possibly explain all of these things that made this virus behave differently than other viruses? The clue, as several of us put together, is probably the ACE2 receptor in the nose. So first of all, what is an ACE2 receptor? You've all heard about it now, but ACE2 receptors are part of the angiotensin converting enzyme pathway. It has to do with renal disease, heart disease. It has to do with how much fluid is maintained in your body. The things that impact ACE2 receptors are obesity, high blood pressure, and age. Other things that impact ACE2 receptors are pollution. If you live in a polluted area, there's an increased number of ACE2 receptors in the nose. ACE2 receptors aren't the only way by themselves that the coronavirus, the SARS-CoV-2 virus, gets into the system. Turns out that you have to not just have an ACE2 receptor, but the shape of the ACE2 receptor and the other genes that are turned on nearby, a TMPRSS2 receptor, a recently discovered heparin receptor. Those two things make it so that the ACE2 receptor can hold on to the coronavirus, and once it gets in there, then it has to fuse with the cell to enter. So there's a number of different steps, but all the research started coming toward the ACE2 receptor. Now, there are ACE2 receptors all over the body, but we started focusing on ACE2 receptors in the nose. Why? First of all, ACE2 receptors in the nose fit almost all of these things. A very recent piece of evidence found that the ACE2 receptors in the nose are different based on race and based on not age necessarily, but based on telomeric shortening, which has to do with how much stress you've had. So they found that the ACE2 receptors in the nose had a change in the DNA that made them stiffer and easier for the coronavirus to hook onto. They're not just sitting on a little flat plane inside the nasal mucosa. Who knew? The ACE2 receptors that are where coronavirus enters are on something called ciliated epithelia. So what are cilia? Cilia are wavy little pieces of cells that have flippers on them. So not only does the virus have to get on the cup at the end of it, but the cilia are moving all the time. So recent paper found that particularly in African Americans and those who've had more stress in their lives, there's a change in what's called the methylation of the ACE2 receptor on the cilia, which makes it less wiggly, easier for the thing to grab onto. So not only does it go into the nose, but it turns out that the ACE2 receptors other places in the body don't have the TMPRSS gene turned on, and they don't have the heparin gene turned on immediately. That takes about 5 to 7 days after it's been primed by the immune system through infection in the nose. Looking at the number of receptors for ACE2 that have all the parts that they need to, they're overwhelmingly in the nose. They're not in the lungs, they're not in the heart, all of that comes later, but where it starts is the nose. So other things that this nasal theory supports. Older people, particularly older men, have larger nasal cavities. African Americans have lower pH in their nose, which may make it easier for the virus to fuse. Dense living, where it's polluted, increases ACE2 receptors. But this was another part of it that was really critical that we're now understanding. This dense living and increase in illness and death is also related to Southeast Asians not getting it as much. It's also related to a number of things, but primarily it's related to masks. Viral load in the nose is what tips your immune system into caring that you've been exposed to this disease. So this is why instead of asthma and allergies making coronavirus worse or making people more susceptible to coronavirus, turns out they're actually protective. And the reason is because the nose in adults and children with allergies and asthma has tuned down ACE2 receptors because they're busy fighting allergies and asthma. So the other part of this with masks is that in order to really get sick, you need to have every ACE2 receptor that you have occupied by a SARS-CoV-2 viral particle up to 10 to the 5th particles until it triggers your immune system. So if you're constantly having a snotty nose, if you're constantly downregulating your ACE2s, you don't get enough of a viral load. If you are constantly wearing a mask, then even if you're in a place where the virus particles are suspended in aerosols and can get through, you're going to remove some of the virus particles getting in through the mask. So the dense living being worse, the Southeast Asians wearing masks and having less death and fewer cases, all of this fits together with a large number of virus particles that are necessary to cause illness, to tip off all the immune system things, and having pre-existing conditions that increase the number of receptors that you have in your nose and the behavior of the ACE2 receptors that you have in your nose. So all of these things come together to explain most of what we're seeing with this disease. All right, so what do we do about it? Well, it takes a long time to downregulate the expression of ACE2 receptors in your nose. So trying to change the reception is one thing that people have looked at, but it turns out that if you're on an ACE blocker, an ACE inhibitor, it actually doesn't make much difference one way or the other toward getting the disease. So in terms of downregulating the expression, will moving to a place that's not as polluted help? Don't know. Methylation. There's not much you can do about the way that your receptors are stiffened by the methylation of the DNA for the ACE2 receptors. So that explains a lot of what we're seeing with people who've had more stressful lives and with some of the systemic racism that has impacted people of color being able to access healthcare and just to live lives that aren't as stressful. But again, not so much you can do about that. Viral load, though, that's the place where people are trying to have an impact. And the other place is timing. So we know that what we're dealing with is the virus going up into not just the nares, like the external part of your nostrils, but also the nasal cavities. So there are a couple ways you can deal with that, and here are the different studies that are going on. Now there are about 18 of them all over the world that are looking at what can you put up your nose or do to your nose to get rid of the viral load. So first of all, we've already talked about how masks decrease the amount of illness from coronavirus by decreasing the number of viral particles that get up there. If you've already gotten particles up there, what can you do? Well, a couple studies are looking at antimicrobials that will kill coronavirus. Betadine is a surgical antimicrobial, turns your skin orange, and it's used in nasal rinses for people who have chronic sinus infections. The mixture is 1 cup of either boiled or filtered water with salt pods or some sort of saline and ½ a teaspoon of 10% povidone iodine. So a lot of people are looking, first of all, to see whether or not this kills coronavirus. 2 studies now demonstrate that not only does it kill coronavirus, but even if betadine is only exposed to the virus for 15 seconds in a 5% solution, still kills it. So there's a study that's done of an NYU Langone. I believe they are finished recruiting, which must mean that they're in their data analysis. They were looking at doing nasal irrigation for healthcare workers who were potentially exposed to coronavirus. So randomizing them to see if they could prevent people getting coronavirus by using betadine spray. Betadine spray and gargle has been done at the University of Kentucky. And same thing, it's healthcare workers. They did a squirt of betadine before people came in to do their shift, midway through the shift, and after the shift. And they're still analyzing the results, but certainly the number of people who have gotten coronavirus seem to be a whole lot lower than medical workers other places. Vanderbilt is also doing a nasal intervention, but instead of using betadine, what they're doing is using soap. So a little bit of baby soap is called a surfactant, and it breaks down the cell wall of viruses, bacteria, and lots of other things. And so what they're doing is randomizing just nasal irrigation or nasal irrigation with a little bit of soap. One of the things we say in emergency medicine is that the solution to pollution is dilution. So if you're worried about having an infection or having infectious particles, then just flushing it out with saline gets rid of those particles. This works for wound care. Why wouldn't it work for a virus that is very loosely attached to an ACE2 receptor and still has to not only be attached, but also take some time to fuse? So just looking at nasal irrigation, there's a study in the UK that is looking at nasal irrigation with just normal saline versus nasal irrigation with betadine. We are looking at nasal irrigation over 14 days after testing positive, and we're not looking at viral load like the study in the UK is or the study in University of Kentucky. What we're looking at is actual clinical outcomes. So we want to know if you are in that asymptomatic or pre-symptomatic phase and you get coronavirus, is there still time to lower the viral load that's in your nose and replicating enough that it won't trigger this huge immune cascade? Once you're in the hospital, not recommending nasal irrigation. We don't even know right now if it works once you're already positive, but it kind of makes sense. All right, other studies. University of Alabama is one of 3 different places that are looking at a nasal vaccine. So it turns out that if the virus is entering through nasal mucosa, you can actually put a vaccine that will populate the nose and take care of it. If your kid has had a rotavirus vaccine, it's the same concept. You take the vaccine in orally, like we used to with poliovirus, because the virus is entering through the gut. With coronavirus, it's entering through the nose, so why not put the vaccine up the nose where the action is? So There are 3 different groups that are getting positive results and are looking at nasal vaccines, and that's an exciting potential to have. One of them may even have their vaccine ready by the end of the year. And because you have a lower amount that's absorbed when you're putting a vaccine in either through the gut or through the nose, there should be fewer side effects and it should be safer, and you shouldn't have to worry about the fear of getting an injection. All right, a couple other studies that are being done looking at addressing the nose. So one study is looking at wiping betadine into the nostrils. There is another study that is just doing a spray with nitric oxide. Nitric oxide is something that blood vessels make to try to vasodilate, to get the blood vessels bigger, but it also has antimicrobial effects. So a spray that has nitric oxide in it may also be something that could kill or decrease the viral load for viruses that are hanging around inside the nose but haven't yet gotten to the place where they are attached to the ACE2 receptor and fused with the cell to start replicating. I think that's all of the trials that are big deals. So at this point, I would imagine that the NYU Langone prevention study should be coming out first. I am hopeful that we'll see the viral load reduction study come out at least with a preprint in the next month or so. There was a decrease in cases over the summer, lots of places, so many of these trials had a slower enrollment. With things picking up, we're hopeful that we can finish our trial in Augusta with enrolling 10 people a day, needing 200 people in the trial. That would be 4 weeks if we manage to get all the weekdays that we can populated with patients. One other approach that hinges on this support that it's going in through the nose is if you're in a crowded place, simply use something to stop anything from entering your nose. So you could use nose plugs. These swimming plugs are very nice, and if you don't mind looking like a dork, you could put your mask on over it. To my knowledge, no one is actually testing to see whether or not these reduce the transmission of coronavirus. 2 of the studies that I've mentioned previously are looking to see if you get coronavirus, whether or not you decrease transmission to household contacts. We are going to be testing whether or not there's any difference by looking at the people who enroll in our trial and how many people in their household have coronavirus at the beginning of the 28 days and then again at the end of 28 days to see if that makes a difference based on how many times they did their nasal irrigation. No one knows at this point how many times you need to do nasal irrigation to decrease the viral load, either before or after. I am personally doing nasal irrigation after I have been around people who I can't contact trace or people that have not been particularly careful with their own coronavirus contact hygiene. And certainly, anytime I'm in a place with people that I don't know or people I haven't seen in a long time, I'm opening windows, keeping fans on, and we have even bought little fans that go around our necks that will blow the aerosols away from our faces and dilute the intensity so that if we do happen to accidentally nasally breathe it in, there'll be a lower viral load. To kind of wrap this up and to give you the take-homes, coronavirus enters in through the nose. You want to decrease your viral load. We don't know yet whether or not putting something that will kill the virus around your nose and the outer nostrils with a spray or with a full cup of irrigation is going to help. It makes sense. We're doing multiple trials, which we anticipate will be out before vaccines are out, giving us some power over this disease that has messed with everyone. If you are in Augusta, Georgia, we will be beginning the trial there, and we'll put information when enrollment is definitely started. And if you have any questions or interest in what we're doing, please like us on Facebook, put in your questions, check the box that you want more information. And in the meantime, be safe, avoid getting things up your nose, and eventually it'll be okay.